when blood won't stop or can't flow. I am Daniel Rusu, anesthesiologist and intensivist. In this episode, we cover everything you need to know at the bedside: the cascade, the labs, bleeding disorders, clotting disorders, reversal agents, and the special case of neuraxial anesthesia in patients on anticoagulation. Let's begin. Here is our roadmap, 7 sections. We start with the physiology, the cascade, and the cellular model. Then we read the labs. Then we go disorder by disorder: bleeding, then thrombosis, then reversal agents, which you will use in the ICU every week, then the ASRA guidelines for neuraxial anesthesia in anticoagulated patients, which every anesthesiologist must know, and we close with 8 clinical vignettes. Hemostasis has 2 arms that work together. Primary hemostasis forms the platelet plug, fast, temporary. Secondary hemostasis, the coagulation cascade, reinforces that plug with fibrin. The critical teaching point is that the classic cascade is a laboratory model. In the living patient, tissue factor initiates everything, and thrombin is the amplifier. Thrombin activates factors 5, 8, and 11, recruits more platelets, and converts fibrinogen to fibrin. Without thrombin, there is no stable clot. The cascade has 2 arms. The extrinsic arm, measured by the PT and INR, is initiated by tissue factor and factor 7. The intrinsic arm, measured by the aPTT, begins with contact activation through 12, then 11, then 9 with 8 as cofactor. Both arms feed into factor 10. Factor 10 with 5 as its cofactor forms the prothrombinase complex, which converts prothrombin to thrombin. Thrombin does the work. It cleaves fibrinogen into fibrin and activates factor 13 to cross-link the fibrin mesh. That cross-linked fibrin is the stable clot. 6 labs you need to interpret coagulation. PT and INR test the extrinsic pathway, factors 7, 10, 5, 2, and fibrinogen. INR above 1.5 is clinically significant. aPTT tests the intrinsic pathway, factors 12 through 8 and the common pathway. Prolonged aPTT means heparin, hemophilia, or lupus anticoagulant. Fibrinogen below 150 is critical. The clot will not form. Platelets below 50 increases surgical bleeding risk. D-dimer is sensitive but nonspecific, positive in almost any inflammatory or thrombotic state. Thrombin time is prolonged by Dabigatran, which is useful at the bedside. Viscoelastic testing, TEG and ROTEM, gives you the full picture of clot formation and lysis in whole blood. The R-time, or CT, tells you about enzyme activity. Prolonged means factor deficiency or heparin effect. The K-time and alpha angle tell you about fibrinogen and platelet contribution to clot kinetics. The MA, or MCF, tells you about ultimate clot strength, driven 70 to 80% by platelets and 20 to 30% by fibrinogen. LY30 above 8% means fibrinolysis. Give tranexamic acid. Bleeding disorders fall into 2 categories: too few platelets or platelets that don't work, and factor deficiencies. Start by looking at the pattern. Platelet problems cause mucocutaneous bleeding, petechiae, purpura, gum bleeding, heavy periods. Factor deficiencies cause deep bleeding, hemarthrosis, muscle hematomas, surgical bleeding that starts hours later. The labs guide you: low platelet count plus normal PT and aPTT points to thrombocytopenia. Normal platelets plus prolonged aPTT points to hemophilia. Both prolonged points to DIC or liver failure. Hemophilia A is factor 8 deficiency. Hemophilia B is factor 9 deficiency. Both are X-linked recessive. Almost exclusively males, carriers are female. Severity tracks with factor level. Above 5% is mild, 1 to 5% is moderate, below 1% is severe. Severe hemophilia bleeds spontaneously, joints, muscles, intracranial. Treatment for hemophilia. A. Recombinant factor 8 or emicizumab for prophylaxis. Treatment for hemophilia B. Recombinant factor 9. Key trap. aPTT is prolonged, PT is normal. Mixing a study corrects, no inhibitor. If mixing a study does not correct, there is an inhibitor and treatment changes completely. Von Willebrand disease is the most common inherited bleeding disorder. Von Willebrand factor has two jobs. It anchors platelets to damaged endothelium, and it carries and protects factor 8 in the circulation. Type 1 is partial quantitative deficiency. Mild bleeding responds well to DDAVP. Type 2 is qualitative dysfunction. Subtypes matter for treatment. Type 3 is near complete absence. Severe, treat like hemophilia A. The screening lab pattern, prolonged bleeding time or PFA 100, low von Willebrand antigen and activity, often low factor 8. DDAVP works for type 1 and most type 2A. Never give DDAVP in type 2B. It causes thrombocytopenia by releasing dysfunctional multimers. Disseminated intravascular coagulation is not a primary diagnosis, it is a complication of something else. The causes are the same every time: sepsis, trauma, obstetric catastrophe, malignancy, transfusion reaction. The pathophysiology is simultaneous clotting and bleeding. Massive thrombin generation consumes factors and platelets, and secondary fibrinolysis dissolves clots before they form. The lab pattern: elevated PT and aPTT, low fibrinogen, low platelets, elevated D-dimer. Treatment is treat the cause, replace what is missing, cryoprecipitate for fibrinogen below 150, FFP for factor replacement, platelets if below 50 and actively bleeding. Do not give tranexamic acid in DIC without confirmed fibrinolysis on TEG. The liver makes almost every coagulation factor except von Willebrand factor and factor 8. Liver failure therefore causes global factor deficiency plus thrombocytopenia from portal hypertension and splenic sequestration plus decreased clearance of activated clotting factors. The INR is elevated but does not reliably predict bleeding in liver disease. The liver also makes anticoagulant proteins, so the patient is in a rebalanced but fragile hemostasis. For procedures, target platelets above 50 and fibrinogen above 150. INR above 2.5 warrants FFP before high-risk procedures. TEG and ROTEM are more useful than conventional labs in liver failure. The thrombophilias, conditions that tip the balance toward clotting. Virchow's triad, stasis, endothelial injury, hypercoagulability. Inherited thrombophilias include factor 5 Leiden, prothrombin gene mutation, protein C and S deficiency, and antithrombin deficiency. Acquired include Antiphospholipid Syndrome and HIT. Not all thrombophilias require anticoagulation. The decision depends on the event type, recurrence risk, and bleeding risk. Factor 5, Leiden heterozygous after a first provoked DVT. Anticoagulate for 3 to 6 months, then reassess. Antiphospholipid syndrome with arterial thrombosis, lifelong anticoagulation. HIT is an immune reaction not a simple side effect. Heparin binds platelet factor 4, creating a neoantigen. Antibodies form against the heparin platelet factor 4 complex, activating platelets massively, causing both thrombocytopenia and a prothrombotic state. The paradox? The patient is bleeding in the platelet count but clotting everywhere else. The 4T score predicts probability. Thrombocytopenia, timing, thrombosis, other causes. Score of 6 or above is high probability. Stop all heparin immediately and start a non-heparin anticoagulant. Do not wait for the ELISA, argatroban for patients with renal failure, bivalirudin for most others. Never give platelets in HIT. It fuels the fire. Venous thromboembolism, DVT, and PE shares the same pathophysiology, Virchow's triad, and risk factor profile. Massive PE causes obstructive shock, right heart failure, hypotension, hypoxia. Treatment is systemic thrombolysis if no contraindications, alteplase 100 milligrams over 2 hours. Submassive PE, right heart strain without shock, anticoagulate and monitor. Catheter-directed therapy if deteriorating. Stable PE, anticoagulate and discharge. For DVT, proximal DVTs, anticoagulate for 3 months minimum. Distal DVTs, 3 months if symptomatic, monitoring alone if asymptomatic and low risk. DOACs are now first-line over warfarin for most patients. Antiphospholipid syndrome is an acquired autoimmune thrombophilia. 3 antibodies define it: lupus anticoagulant, anticardiolipin antibody, and anti-beta-2 glycoprotein antibody. Positive on 2 occasions at least 12 weeks apart is required for diagnosis. The clinical picture: venous or arterial thrombosis, or pregnancy loss. The lab trap: lupus anticoagulant prolongs the aPTT in the tube but causes clotting in the patient. If a PTT is prolonged and a mixing study does not correct, think lupus anticoagulant. Treatment: warfarin for most patients. DOACs have shown higher thrombosis rates in triple-positive patients and are not preferred. Target INR 2 to 3. Catastrophic antiphospholipid syndrome is a medical emergency. Anticoagulate, give steroids, plasmapheresis, IVIG. Warfarin blocks vitamin K-dependent factors 2, 7, 9, and 10+, protein C and S. Reversal depends on urgency. Life-threatening bleeding, 4-factor prothrombin complex concentrate, PCC 4-factor, plus vitamin K 10 milligrams IV. PCC works in minutes. Vitamin K prevents rebound in hours. Fresh frozen plasma is a second line. Large volumes, slower, less predictable. For urgent procedures with INR above 1.5, PCC, low dose. For non-urgent reversal, hold warfarin, give oral vitamin K. Trap, vitamin K alone takes 12 to 24 hours to work. In active intracranial bleeding, do not wait for vitamin K. Give PCC immediately. 4 direct oral anticoagulants, 3 reversal strategies. Dabigatran, direct thrombin inhibitor, reversed by idarucizumab, 5 grams IV, complete reversal in minutes. Confirm with thrombin time. Rivaroxaban and apixaban. Factor 10A inhibitors, reversed by andexanet alpha, high dose for rivaroxaban or apixaban, taken within 8 hours. Low dose for other situations. If andexanet is unavailable, 4-factor PCC at 50 units per kilogram is the alternative, off-label but used widely. Edoxaban, andexanet alpha or 4-factor PCC, all DOACs. Check timing of last dose, renal function, and whether the drug is even on board before giving reversal. Idarucizumab and andexanet are expensive and targeted. Unfractionated heparin reversal, protamine 1 mg per 100 units of heparin given in the last 2 to 3 hours. Maximum dose 50 mg. Give slowly. Rapid infusion causes hypotension and bradycardia. Low molecular weight heparin. Protamine reverses about 60%. Give 1 mg protamine per 1 mg enoxaparin, if given within 8 hours. For platelet dysfunction, from aspirin or P2Y12 inhibitors, DAV, P 0.3 micrograms per kilogram releases a stored von Willebrand factor and helps platelet adhesion. Platelet transfusion for active life-threatening bleeding on antiplatelet agents. But wait 6 hours after ticagrelor if possible, since ticagrelor remains in plasma and will inhibit transfused platelets. The ASRA guidelines define minimum hold times before neuraxial anesthesia in anticoagulated patients. These are not arbitrary. They are derived from drug half-lives and clearance. Standard heparin subcutaneous, 4 to 6 hours, check aPTT. Enoxaparin prophylactic dose, 12 hours. Enoxaparin therapeutic dose, 24 hours. Warfarin, INR must be 1.4 or below. Rivaroxaban prophylactic, 22 to 26 hours. Rivaroxaban therapeutic, 44 to 65 hours. Apixaban prophylactic, 26 to 30 hours. Apixaban therapeutic, 40 to 75 hours. Dabigatran, 72 to 96 hours for CRCL above 80. Longer for renal impairment. After catheter removal, restart anticoagulation no sooner than 12 hours for prophylactic, 24 hours for therapeutic dosing. When in doubt, call the ASRA hotline. These guidelines update and the stakes are a spinal hematoma. A 22-year-old male presents with severe right knee pain and a swelling after minimal trauma. No significant medical history. aPTT, 68 seconds, PT normal, platelets normal. The bleeding pattern, hemarthrosis after minimal trauma in a young male, points immediately to hemophilia. Prolonged aPTT with normal PT confirms intrinsic pathway deficiency. Send factor 8 and factor 9 levels. Factor 8 level comes back at less than 1%. Hemophilia A severe. Give recombinant factor 8, dose in units equals weight in kilograms times desired percent rise times 0.5. For a hemarthrosis target factor, 8 level above 50%. The trap. If the mixing study does not correct the aPTT after giving factor replacement, there is an inhibitor. Check a Bethesda assay. Management changes to bypassing agents. Recombinant factor 7A or FABA. A 68-year-old woman on warfarin for atrial fibrillation falls and sustains a subdural hematoma. GCS is 11. INR is 3.2. This is life-threatening intracranial bleeding on anticoagulation. Do not wait. Give 4-factor PCC immediately, 50 units per kilogram, plus vitamin K, 10 milligrams IV. Recheck INR in 15 minutes, target below 1.4. Neurosurgery is already at the bedside. Do not give FFP as the primary reversal in intracranial hemorrhage. It takes too long, and the volume load worsens intracranial pressure. The trap. Once reversed and the acute crisis is managed, you will need to decide when to restart anticoagulation. For subdural hematoma in atrial fibrillation, most guidelines suggest 4 to 8 weeks minimum before restarting, with shared decision-making on a stroke versus rebleed risk. A 55-year-old man is on day 7 of heparin infusion for DVT. Platelets have dropped from 200 to 80, a 58% fall, no other explanation. 4 T-score, thrombocytopenia, 2 points, timing 2 points, classic day 5 to 10 fall. No thrombosis yet, 1 point, no other cause, 2 points. Total, 7. High probability HIT, stop all heparin immediately, drips, flushes, heparin-coated lines. Start argatroban. This patient has mild renal impairment, so argatroban is preferred over bivalirudin. Send ELISA for heparin PF4 antibody, but do not wait for the result. The trap: platelet transfusion is contraindicated. Transfusing platelets gives fuel to the antibody-activated platelet response and can trigger limb-threatening or life-threatening thrombosis. A 29-year-old woman at 34 weeks gestation develops abruptio placentae with heavy vaginal bleeding. She becomes hypotensive, labs return, platelets 60, fibrinogen 80, PT and aPTT both prolonged, D-dimer elevated. This is obstetric DIC. The cause is massive tissue factor release from the placenta. Treat the cause first. Delivery: simultaneously replace cryoprecipitate 10 units to raise fibrinogen above 150, FFP for factor replacement, platelets to above 50. Tranexamic acid 1 gram IV is supported by the woman trial for postpartum hemorrhage. It reduces mortality if given within 3 hours of bleeding onset. Do not give heparin in obstetric DIC. The fibrinolysis here is secondary, not primary, and heparin will worsen bleeding. A 72-year-old man on apixaban 5 milligrams twice daily for atrial fibrillation requires emergent hip replacement after a fall. Last dose was 4 hours ago. Creatinine clearance is at 45. This is urgent, cannot wait, the standard 40 to 75 hour hold time. Options: andexanet alpha, high dose, since apixaban was taken within 8 hours. If unavailable, 4-factor PCC, 50 units per kilogram. Check anti-XA level, if available, to confirm drug is on board before giving reversal agent. After the procedure, restart apixaban no sooner than 48 hours given high bleeding risk of hip replacement. The trap: do not assume the apixaban is gone because the patient says they may have missed a dose. With a CRCL of 45, half-life is prolonged. When in doubt, measure the drug level. A 38-year-old woman with known antiphospholipid syndrome presents with her third DVT. She has been on rivaroxaban, triple positive, lupus anticoagulant positive, anticardiolipin IgG elevated, anti-beta-2 glycoprotein IgG elevated. Rivaroxaban is the wrong drug for triple positive antiphospholipid syndrome. The RAPS and TRAPS trials showed higher thrombotic event rates with DOACs versus Warfarin in this population. Transition to Warfarin. Target INR 2 to 3. Explain to the patient that triple positive antiphospholipid syndrome means lifelong anticoagulation, regardless of whether events were provoked. The trap: the aPTT is elevated at baseline due to lupus anticoagulant, making heparin monitoring by aPTT unreliable. Use anti-XA levels or chromogenic heparin assays when bridging this patient. A 51-year-old man with decompensated cirrhosis presents with variceal bleeding. INR is 2.8, platelets are 42, fibrinogen is 110. He is already on octreotide and antibiotics. Do you give FFP? The conventional answer would be yes, but the evidence is weak. The INR in liver failure reflects decreased procoagulant factors, but not decreased anticoagulant protein C and S. Both are also low, leaving the patient in fragile rebalanced hemostasis. FFP may not help and can worsen portal hypertension. Better strategy: give cryoprecipitate to raise fibrinogen above 150. Transfuse platelets to above 50 if actively bleeding. Consider tranexamic acid and proceed urgently to endoscopy. Band ligation or sclerotherapy is the definitive treatment. Thromboelastography is more informative than INR in this patient. An 81-year-old woman on Dabigatran, 110 milligrams twice daily, presents with acute ischemic stroke at 65 minutes from onset. Thrombolysis is being considered. Last dose 6 hours ago, creatinine clearance 38. Can you give TPA? No. Dabigatran anticoagulation is a contraindication to thrombolysis. The correct path: give idarucizumab 5 grams IV, 2.5 gram vials given back to back. Complete reversal in minutes. Confirm with thrombin time, or it should normalize rapidly. After reversal, proceed immediately to mechanical thrombectomy. Do not give TPA even after reversal. Reversal occurred too close to the procedure, and thrombectomy is the definitive treatment. The trap: checking only INR or aPTT for Dabigatran. INR can be normal or minimally elevated even with full Dabigatran anticoagulation. The test for Dabigatran is thrombin time. A normal thrombin time essentially rules out clinically significant Dabigatran effect. Always check thrombin time when Dabigatran status is uncertain. A 60-year-old man on enoxaparin 1 milligram per kilogram twice daily needs an epidural steroid injection for lumbar radiculopathy. His last dose was 18 hours ago. Can you proceed? No. Therapeutic enoxaparin requires a 24-hour hold before Neuraxial procedures. Wait 6 more hours, recheck, and proceed only if no dose has been given in 24 hours. For catheter removal, wait 24 hours after the last therapeutic dose before pulling the catheter, and do not restart enoxaparin for at least 2 hours after removal. The stakes: spinal epidural hematoma causing cord compression. If a patient develops new back pain, leg weakness, or bowel or bladder dysfunction after a neuraxial procedure on anticoagulation, emergent MRI. Surgical decompression within 8 hours is the window for meaningful neurologic recovery. Screenshot this slide. This is the complete coagulation reference you need at the bedside. 6 domains: primary bleeding, platelets and von Willebrand factor, factor deficiency, hemophilia, liver failure, DIC, thrombosis, HIT, PE, DVT, Antiphospholipid Syndrome, reversal, every drug with its antidote, ASRA, Neuraxial hold times, and TEG and ROTEM interpretation. These 6 boxes cover 90% of coagulation problems in the ICU and the operating room. That is Euboxia Episode 3, Coagulation. 6 things you can now do that you could not before this episode. Name the reversal agent for every anticoagulant. Apply the 4T score and act on HIT before labs confirm it. Know the ASRA hold times as reflex knowledge. Treat DIC by fixing the cause, not just replacing products. Interpret a TEG or ROTEM and translate it into product orders, and distinguish von Willebrand disease types and know when DDAVP will help versus harm. Episode 4 covers hemodynamics. I am Daniel Rousseau. Thank you for watching.